I'd like to invite our next speaker now, who is Dr. Cecelia Gzell from New South Wales. She is a radiation oncologist, has a special interest in neuro-oncology and gamma knife. She has come highly recommended with a lot of great experience in skull-based radiosurgery and treatment for this. Cecelia, you may or may not be aware that our patient Jack, who spoke earlier, has had radiosurgery down here, I think with Genesis Healthcare down here. Actually, may not be Genesis, I said the wrong thing, but with Neda's group here. And at 11 months, he's had a cortisol now, which has halved in levels, which is quite pleasing from his perspective. And and certainly he thought that radiosurgery, from his perspective, was actually quite a good experience, I guess. So I'd like to be interested to hear your thoughts on that, and you can have a chat about radiosurgery for Cushing disease. Thanks, Cecelia.
Thanks, Ian, and thank you to the Foundation for inviting me to talk today. So like Ian mentioned, I'm going to talk on radiosurgery for Cushing's disease. And just a quick overview of the things that I'll be discussing today. So firstly, evolution of different radiotherapy techniques. What is radiosurgery? The different modalities that we use to deliver radiosurgery, our expectations of success in Cushing's disease, a couple of case examples, and briefly on some toxicities. So, evolution of radiotherapy.
Cecelia, you might have to play your slide screen.
Can you not see them from your end?
I can see the PowerPoint, but not the actual presentation.
Oh, okay. So I did click on that a couple of times. Let me just try that again. I'm sorry.
So the bottom, yeah. That.
Can you see it now on your end?
It's coming.
Just let me know when you can.
Can anyone else see the actual presentation slides as yet as a slideshow?
Yeah, not yet. I'm still seeing the PowerPoint as well.
Let me just try if I stop sharing it again, and then I'll try sharing it again. So I've just tried stopping and starting. How are we going?
Yeah, so same. We still just got the overview of the PowerPoint.
Okay.
And is it running the screen on yours?
It is, yeah. So let me try get rid of it again for a sec, and we'll see if I can get it out. How about now?
Yeah, perfect.
Okay, great. So what it wanted me to do was actually put the full PowerPoint slides up on mine without then, anyway, doesn't matter. It's all good. So where are we up to? Now the problem is it's not moving along. Which slide can you see on your screen at the moment?
The title slide still, radiation surgery for Cushing's disease.
Yeah, unfortunately now it's not actually letting me advance the slides. Good. Okay.
There you go.
That was
perfect.
Good. Excellent. So sorry for that delay. So this was just quickly the overview that I mentioned, and we'll start with evolution of radiotherapy. So these are the modern techniques of radiotherapy, and in fact, 3D conformal radiotherapy is what was the standard treatment when I was a young trainee back in the early 2000s and late 90s. And this involves static radiotherapy beams with some field shaping involving multi-leaf collimation or MLCs. And I'll show you a picture of that in a moment. But there was lots of normal tissue dose. Now, Ian, I don't know if you can help. Someone's got their microphone on and there's a lot of
You're right. Now, let me try to hello. Yes, you're right.
Can you mute whoever's got their microphone on?
Can you mute Kim at all? I actually know who that is too. Okay. I can see which one it is. Okay,
Okay.
perfect.
Great, thank you.
That should be, thank you.
Much better. I'll keep going. So, and then in the sort of the mid 2000s, we moved to IMRT, or intensity modulated radiation therapy. And then in the sort of 2010s era, we've moved on to VMAT, which is volumetric modulated arc therapy. And both IMRT and VMAT involve dynamic shaping of multiple beams or arcs, which enabled for far better dose conformality and much less normal tissue dose. And I'll show you a picture in a moment. But this is actually just a picture of the MLCs, and these are lead leaves. And you can see they're in a shape which would have been, you know, the shape of the target. And back in 3D conformal, these leaves were fixed in those positions and the beam passed through that. And so the bit that was blocked, and the beam passed through the open area. But when we moved on to IMRT and then VMAT, those leaves were moving constantly as the beam of radiation is being delivered. And that was what enabled much tighter dose conformality and also a steeper drop-off of dose beyond the target. And this just gives you an example of that. So this is an IMRT plan. You can see both on the left, the 3D conformal plan, and on the right, the IMRT plan. And so what I've got there is I've got a red line, which is the target, and the red shading is the target dose. And you can see with 3D conformal, even with that kind of shaping with the MLCs, it's still a bit boxy. And what's really obvious is that green shaded area is actually about 2/3 of the dose, and that's all going to normal brain tissue on the other side of the target. Whereas with IMRT, the red shading is pretty tight to the actual target, and that 2/3 dose is also quite tight to the target. So we're not seeing lots of normal tissue dose. Well, what about radiosurgery? So stereotactic radiosurgery requires additional fixation. So that's a mask with extra support or a head frame, and I'll show you a couple of pictures in a moment. It also requires real-time image guidance so we can be more accurate. So what we want with radiosurgery is to be accurate to less than 1 millimeter, compared with about 3 millimeters for sort of standard brain work other than radiosurgery. It also requires additional quality assurance. So there's extra physics testing required to ensure that we're doing that precise delivery with the really steep dose gradient. And this is a picture of the different fixation devices. So on the left, we've got a fixed head frame, and so we use that for gamma knife surgery. In the middle photo, that's actually a standard mask. So that's more used for standard brain treatments for other types of tumours rather than what we'd be doing for pituitary work. And on the right is a relocatable mask that we would use for stereotactic radiosurgery. And that mask has a mask actually across the front, but also across the back of the head, has extra support across the chin and forehead, and that enables it to be much more precise rather than that middle one. So the head frame for gamma knife surgery is actually precise down to 0.5 of millimeter, and the SRS mask is precise to about 0.7. So they're quite close. But certainly much more accurate than the standard mask that we use for other treatments. So stereotactic radiosurgery is defined as 1 to 5 treatments, and it's a large dose of radiation in each of those treatments. Whereas stereotactic radiotherapy is generally a low dose per treatment, but you're often giving it every day up to 6 or more treatments. And it's also known as fractionated stereotactic radiotherapy, or FSRT. So what are the different modalities that we might use to deliver this treatment? So the first is the linear accelerator, or LINAC. And this is an X-ray generating machine. It's actually the workhorse of what we do almost all our radiotherapy on. It delivers very high energy X-rays or electrons to a target, but it can be adapted for stereotactic radiosurgery or stereotactic radiotherapy, requiring a bit of additional equipment and extra commissioning. And it also requires high quality real-time image guidance for verification. And this is actually a picture of a LINAC set up for stereotactic radiosurgery. So hopefully my pointer will work, or it may not. No, unfortunately my pointer's not going to work, but what you can see on the left picture is the full machine. So the big sort of round area with the arm is what we call the head and the gantry. And then you've got the bed, and you can see a green mask locked in on the bed there. And over that is what we call a fiducial box. So that's helping us get the patient set up very accurately. And then there are a couple of screens in the picture, and that's for the real-time image guidance. Again, so we get the patient set up, and then we do some imaging with low-dose cone beam CT usually. Also orthogonal x-rays, so just standard x-rays, but done in different positions. Make sure we've got the patient in the correct position before we actually deliver the treatment. Now this is for a LINAC. These are a picture of what we call cones. So you can see lots of tiny different apertures there, from 5 millimeters all the way up to about 25 millimeters. And these would be attached to the head of the machine, and the beam of radiation will pass through those tiny apertures, meaning that only what's open is going to be delivered. And so we do use that for stereotactic radiosurgery. Sometimes we also use those MLCs, the picture that I showed you before. So that might be those larger MLCs, or we might use what's called mini MLCs, and that depends on the type of machine that's being used. But that just shows you a bit more of the equipment, and you might have heard the word cones at some point. The other option is gamma knife surgery. So a bit different. Instead of having a machine that generates high energy X-rays, we've got a machine that houses 192 very, very tiny radioactive sources. So these are cobalt sources, and they're delivering gamma rays. And this is a dedicated machine that just does stereotactic radiosurgery for brain treatments. And in fact, the specifics down the bottom are probably not particularly helpful for you, but the collimator sizes are, after you've just seen those pictures of the cones that we would use on a linear accelerator. Instead of having lots of different options, we only have 3, but we only need the 3, 4, 8 and 16 millimeters in order to manipulate them into delivering what we want for the individual patient. And this is what the gamma knife unit that I work at looks like. So that's the bed in the first picture on the left, and the machine has all the covers on it. There's a little semicircular cradle there where the head frame attaches into it. And the picture on the right shows you a patient as we're getting them linked up into that cradle, ready for treatment. Now the picture down the bottom shows what's actually happening behind all those covers. So up the top is where all the little cobalt sources are actually housed. So they're housed up in lead shielding, and then we're able to manipulate them down into those different dwell positions as required in order to deliver a treatment for the patient. And so what about our expectations for Cushing's disease? So the role of stereotactic radiosurgery or stereotactic radiotherapy is usually a second-line treatment, as Dylan mentioned before. So it's often for inoperable recurrence or to treat the cellar when the biochemical remission hasn't been achieved post-surgery. After we give radiation, biochemical remission can be achieved at up to 80% of patients, and usually that is maintained. But it can take up to 3 years to achieve that, with a range of around about 12 months to 36 months. Now, specifically for Cushing's, it is preferable to give a large single fraction, so stereotactic radiosurgery. And if we're able to do that, usually the biochemical remission is achieved more quickly. It's certainly preferable for what we call functional tumours, so things like Cushing's disease or prolactin secreting tumours. They do tend to require the bigger dose of radiation, and we find that that's definitely going to achieve a better outcome. But actually, radiation is very effective at stopping the tumour from growing. It's the biochemistry that takes a little bit longer. So what about stopping the somatostatin analogue? So this is a little bit more controversial, and in fact, the data on this is somewhat conflicting. But there is the question of whether, if a patient's on the medical therapy, it might reduce the efficacy of stereotactic radiosurgery. So usually there's a discussion between the radiation oncologist and the endocrinologist, and if it's possible, we would try to withdraw the treatment 2 months before the radiation was delivered. And I briefly just want to show you some case examples. So the first one is a 45-year-old lady. Now, she had salvage hypophysectomy 3 years prior to coming to see me, and her original transfemoidal surgery was 4 years previously. She'd had 8 months of, after the surgery, she'd had weight gain, she became quite Cushingoid, She'd had a trial of Dostonex, but had ongoing elevated cortisol levels. And she came to me and I gave her Linac-based SRS to the cellar. So this just gives you a couple of pictures of her radiotherapy plan. So the pink shaded area is the target. So that's the entire cellar or pituitary fossa. The little yellow shaded area is the optic chiasm. The green shaded area is the brainstem, and you've got the globes or the eyes at the front. Now, we've got a couple of lines there showing you the doses of radiation. And probably the most useful is the light green colour, which is showing you the target dose covering that cellar quite nicely. And the dark blue line, which is well less than half the dose, is still clear of the optic chiasm. And in fact, that's a dose that is tolerable by the optic apparatus. So we've been able to deliver the target dose to the target whilst preserving the vision, because obviously that's a very important aspect of delivering the treatment safely. And that particular patient, she actually achieved biochemical remission by 2 years. At that point, she'd lost more than 20 kilograms of weight. She had resolution of all her Cushing symptoms. And at her last follow-up, which was 4 years after her radiotherapy, the remission was maintained. However, she'd started to require a small amount of cortisol replacement at that point in time. And moving on to the second case, this patient had her original surgery about 5 years prior to presenting to me. She'd never really achieved biochemical remission, and she had been on Dostonex and had now developed a recurrent nodule. And I gave her Gamma Knife to that. And actually hers was quite interesting, because when I first met her, I wasn't sure if we'd be able to deliver it as the single fraction, given the proximity to the optic chiasm. But the only way I thought we'd be able to achieve that would be with Gamma Knife rather than the Linac, just because of differences between the two modalities. But in fact, it was a beautiful plan. And you can see there on the left, the yellow is the target dose, and you can see the mass inside that. And the green is a much lower dose. And the yellow is sort of dipping under and coming back up. So we're sort of sparing the optic chiasm. And the green dose, which is tolerable by the optic apparatus, is going through part of the chiasm. But again, it's a tolerable dose, so it's an acceptable outcome. If this was done on a linear accelerator, there's no way she would have been able to have a single fraction. We would have had to give her the standard sort of 6 weeks of treatment, which definitely has a lower success rate. And obviously also there's the inconvenience of having to come in every day for 6 weeks. So with Gamma Knife surgery, we were able to keep the dose of the chiasm below the standard limits. I don't have any outcome data because this was only a month or so ago, but it was a really nice plan. So I wanted to show it from that perspective. So lastly, just wanted to cover toxicities briefly. So generally it's very well tolerated, especially if we're talking about a single fraction of treatment. The risks are low, so risk of damage to the vision should be less than 1%. So if you're meeting those standard targets of what we want the dose to be below for the optic apparatus, the risk is well less than 1%. There is still a small risk of stroke longer term. The big carotid arteries are right next to where we're treating, so that's a 1% risk, and that's a long-term risk. There's an inflammatory reaction that can happen after radiation in about 3%. Most of the time, patients have no symptoms. We see it on a scan and it goes away of its own. And as Dylan mentioned before, risk of other hormonal functions of pituitary not working. I'd usually quote 30 to 50% by 10 years. But we always have to remember that that's multifactorial. The surgeons can't get away with everything. The surgery also carries a risk of causing damage to pituitary function. So it's a combination of all the treatments involved. And luckily, we're in an era now where pretty much every one of those hormones can be replaced by the endocrinologist. So at least we have that, even though it is a fairly common risk. I think that was the last slide. So thank you.
Okay, perfect. Thanks so much, Cecelia, for going through that really quite detailed talk showing where we've come from and where we are going to. I do like how we now do have a radiosurgery to give good options for patients. And I guess as a neurosurgeon, more and more we're seeing that the term radiotherapy, nowadays there is a lot of radiosurgery because we do actually now means that we don't need to do microsurgery or neurosurgery. And for skull-based lesions like the pituitary gland, it is just as safe. You can see that Cecelia said the risk to the optic apparatus of vision is less than 1%. When we do surgery, a lot of times the risk of to the vision is about 1%. Also, the risk to the pituitary gland over 30% over 10 years, risk of getting hypopituitarism, which is lack of hormonal use. But when we operate, there's an immediate sort of 6 to 8% risk of that can happen. So if the risk factors are equivalent, I think I might ask Jack this earlier afterwards. What is the patient's perspective in terms of having radiosurgery versus microsurgery? Because the patient may actually prefer coming in for 1 to 5 fractions, where they lie there for a few minutes, rather than having a full anaesthetic and actually having brain neurosurgery. So great insights there, Cecelia. So thank you for that.